Hi, and welcome back to the Pro PA podcast. I'm angiography, your host for this cardiovascular series. Today we're diving into thoracic aortic aneurysm, a critical vascular condition that clinicians need to be able to recognize. We'll cover everything from pathophysiology to diagnosis, management, and key clinical pearls. Whether you're preparing for the PANCE or a practicing PA, this episode will give you the essential takeaways. Let's get started. Let's begin with some basic pathophysiology. A thoracic aortic aneurysm, or TAA, is an abnormal dilation of a segment of the thoracic aorta, usually the ascending aorta, due to weakening of the vessel wall. This can occur secondary to chronic hypertension, genetic disorders like Marfan's or Ehlers-Danlos syndrome, Turner syndrome, bicuspid aortic valve disease, or atherosclerosis. Over time, progressive dilation increases the risk of rupture, which is a life-threatening emergency. And one last little note here is that TAAs are less common than abdominal aortic aneurysms, or AAAs. Now, who do TAAs affect? Thoracic aortic aneurysms are more common in men and in those of advanced age, particularly men over 60. The majority of TAAs are degenerative, so risk factors include smoking, hypertension, and hypercholesterolemia. Genetic syndromes play a role in the population of patients under 65 years old. Moving on to the clinical presentation, TAAs are often asymptomatic and detected incidentally. When there are symptoms, this indicates expansion of the aneurysm and therefore there's an increased risk of rupture or dissection. Symptoms may include chest or back pain, hoarseness from compression of the left recurrent laryngeal nerve, dysphagia from esophageal compression, shortness of breath from phrenic nerve compression, cough, wheezing, dyspnea, or hemoptysis from compression of the tracheobronchial tree, aortic regurgitation due to aortic root dilatation, neurologic symptoms from aortic arch branch vessel compression, or superior vena cava syndrome from compression of the central veins or superior vena cava. In the case of a rupture, though, patient may have severe chest pain, hypotension, and present in shock. As far as diagnosis, a TAA is commonly detected as an incidental finding on imaging for an unrelated condition. On chest X-ray, TAA produces a widening of the mediastinal silhouette, enlargement of the aortic knob, displacement of the trachea from the midline, and aortic calcification may also be present. However, it cannot distinguish TAA from a tortuous aorta, and therefore when a TAA is suspected, advanced imaging is necessary to confirm the diagnosis. CT angiography is the modality of choice. Additionally, if there is need to evaluate the aortic valve or check for other cardiac abnormalities, a transesophageal or transthoracic echocardiogram is reasonable. Now, let's move on to the management. Indications for repair depend on the location of dilation, rate of growth, associated symptoms, and overall condition of the patient. Although some cases will require surgery sooner, generally, asymptomatic aneurysms may be considered for repair when they measure 5.5 centimeters. These patients will need to have aortic expansion monitored through surveillance imaging. In addition, if a patient is symptomatic or has a growth rate of greater than 0.5 centimeters per year, these are indications for surgery. And of course, a patient presenting with a TAA rupture needs emergent repair. For patients with asymptomatic TAA who are being monitored, control of hypertension is recommended to limit further aortic expansion. A beta blocker is recommended with a goal systolic pressure of 105 to 120 millimeters of mercury if tolerated. In addition, as we discussed earlier, most patients have concomitant cardiovascular disease. Thus, managing cardiovascular risk factors such as smoking cessation, antiplatelet therapy, and statin therapy is also important. Regarding prevention, this involves reducing cardiovascular risk factors, like we already mentioned, such as hypertension control, smoking cessation, and lipid management with statins to slow aneurysm progression. And routine screening may be indicated for patients with genetic syndromes. Here are some clinical pearls. Number 1. TAAs are often asymptomatic and detected incidentally. Number 2. A widened mediastinum on chest X-ray warrants further evaluation with CT angiography. And number 3. Beta blockers reduce aortic wall stress and are the mainstay of medical management. All right, let's get some practice in. Question 1. A 65-year-old man with hypertension and a 40-pack-year smoking history undergoes a chest X-ray for a chronic cough. The radiologist notes a widened mediastinum. Which of the following is the next best step in evaluation? Is it A, pulmonary function testing, B, CT angiography of the chest, C, cardiac stress test, or D, esophagogastroduodenoscopy? I'll give you a couple of seconds. If you chose B, CT angiography of the chest, you are correct. A widened mediastinum on chest X-ray raises concern for a thoracic aortic aneurysm, and CT angiography is the modality of choice for diagnosis. It can detect the aortic diameter, vessel anatomy, dissection, rupture, and thrombus. Question 2. A 55-year-old man presents with an incidentally found 5.8 centimeter ascending thoracic aortic aneurysm. He is asymptomatic. Which of the following is the next best step in management? Is it A, manage medically and re-image in 6 months? B, refer for surgical repair? C, initiate statin therapy and re-image in 1 year? Or D, start dual antiplatelet therapy? If you chose B, refer for surgical repair, you are correct. Ascending aortic aneurysms greater than 5.5 centimeters require surgical repair due to the high risk of rupture. Great job! That wraps up our discussion on thoracic aortic aneurysms. Recognizing these early can save lives, so make sure you keep these key points in mind. Don't forget to subscribe and turn on notifications for more episodes covering cardiovascular topics. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.